All right. Well, I just want to say welcome, and there's a lot of variety of subspecialties represented in the room today. So the first portion of this is going to be a little bit of a review for some of you that are already ECMO specialists and have already gone through training. But really, the goal of this weekend is to pull all of the subspecialties together and have all of us on the same page and the same level of understanding, because really we're here to understand how hemodynamics interfaces with Impella and interfaces with ECMO. How do the three entities coincide? And it's really a medical strategy of how to optimize the best care for the patient. So, all right, sometimes we speak about ECMO as extracorporeal membrane oxygenation, meaning that it is a technique of taking the blood outside of the body and running it through a pump, running it through an oxygenator, and returning it back to the body. Sometimes we also call it extracorporeal life support. Dr. Malik in particular really likes that phrase because it is one of the highest levels of life support. And so we want to convey that to the family when they ask us and they say, how are they doing? Oh, they're great. They're having a great day. Okay, well, it's good or it's great in relationship to the fact that they're on an extreme amount of life support. So, what is ECMO? What does it do? It is a mechanical circulatory support that can help support the heart or the lungs in terms of giving them extra support when maximum medical therapies have failed. So we have maximized other cardiac medical therapies. We have maximized inotropes, vasoactive meds. We may have added Impella or other VAD or things like that. We may have had them on maximum ventilator settings, but all of our medical therapies have failed, and that's why we're escalating to ECMO. It needs to be a patient with an acute recoverable disease. So we're not really trying to do this for patients that have long-term chronic illnesses. It really is intended to be saving that patient that has an acute process and trying to get them to overcome that acute process. There's no age limit, so we use it in neonates, pediatrics, and adults. They use it all the way up to 90 plus years of age. The thing that you have to think about and consider, though, is the quality of life. So if it's a 90-year-old that's really active and has a good quality of life, and this is just an acute process to get through, then that might be beneficial. But there's no age threshold, but older age is, something that you have to consider. It is a bridge, so it's a bridge to decision making, like if you're in the ER and you're thinking about ECPR because they came in, they have a downtime, they're in cardiac arrest, either inpatient or outpatient. You might use it as a bridge to decision. You might use it as a bridge to complete recovery, or you might use it as a bridge to a durable VAD. So there are two different kinds of ECMO, VA and VV, and then there are a lot of kind of subcategories of different cannula configurations that you can add to make it even more than these two. But essentially, so blood is draining from a vein, a large vein, and if it's returning to a vein, then it is veno-venous or VV ECMO. If the blood is draining from a vein and returning to an artery, then it's veno-arterial ECMO, so it's VA ECMO. So sometimes there's some misconceptions that I think we want to really help the families to understand that ECMO is not in and of itself a treatment. So what it is it is mechanical, circulatory, and ventilatory support that gives the patient time for their heart and or lungs to recover from their underlying disease process. So physicians are going to treat the underlying disease process, and ECMO is just going to be a support to, carry that patient through with heart or lung and or lung support during their illness. So there's no set time for recovery. And we should talk about on the front side what the end point is going to be. So if it is a patient that has had, CPR, then we don't know necessarily what their neurological status will be. So we're just helping bridge that gap to decision maybe, with a goal of recovery. But we need to talk about, are they a transplant candidate if they're a heart? Are they a VAD candidate if they're a heart? We want to have those conversations really in the beginning with the family so that they're not surprised that later down the road we're thinking about these types of other therapies. The only absolute contraindication to ECMO is if you truly anticipate no recovery. So someone that has terminal cancer, someone that has a long history of cardiac failure, and it's already been determined, not a bridge to transplant, not a VAD, something like that. So those patients, if there's no clear endpoint, no clear recovery, then we wouldn't put them on ECMO. Now the key is early recognition and early intervention, and she talked about this even in hemodynamic support. So that's where all of you come in, because you're the first line people at the bedside. So you need to help the physician teams recognize that this patient might be a candidate for ECMO and have that early recognition, early referral, so we could do early intervention. And if a patient has been on prolonged mechanical ventilation for a long period of time, especially with high ventilator settings, then their recovery statistics are lower because we've waited too long to add them. This is just a slide to give you the comparative options of escalation of support. So basically you start with maximum medical therapies, and then you progress to possibly considering an intra-aortic balloon pump, considering an Impella device, or any kind of VAD or tandem heart device. And then if those are not enough and or you need oxygenation, then that's when we would add ECMO. So again, we would want to really assess the right candidate, like Dr. Inslee had said, VV or VA. It's not just deciding ECMO, but deciding the right type of therapy of ECMO. And then beyond ECMO, then you have transplant or durable VAD or a complete recovery. So these are some of the relative contraindications. So nothing is truly absolute except for non-recovery, but these are things to keep in mind with a relative contraindication. So if you have a patient that has a significant CNS injury, so they have significant bleeding, like a hemorrhage, subarachnoid bleed, significant neurodevastation, then typically those aren't the best candidates for ECMO. If they have any kind of irreversible CNS injury, we're really trying to help preserve their quality of life. If they have systemic bleeding or they have anticoagulation coagulopathies, that's something that's not absolutely out of the question. It's just something that has to be considered in the strategy of how you manage ECMO. So we had a patient recently that had a coagulopathy. There was just a time that we did no anticoagulation while she was on ECMO. So it's not an absolute, but just something to consider in the strategy of how you manage it. Again, liver cirrhosis, that's going to contribute to kind of having a long-standing coagulopathy. If they're immunosuppressed, it's something to consider, but it's not absolutely out of the question. And then if they have, like I said, any kind of severe heart disease that they've already been evaluated for, and for whatever reason they're not a candidate for a VAD or for transplant, then we probably, ECMO probably wouldn't be the right fit for them. If they already have a poor life expectancy with malignancy or end organ failure, then that's something that we would consider may not be the right fit. And we kind of talked about age. It's just a consideration. You want to just know how well they'll tolerate it, but there is no absolute age threshold. And so again, if they have had a long time of mechanical ventilation, then they're less likely to recover. All right, I want to just give you a little bit of history because kind of like Dr. Inslee walking down, like memory lane, why have we not done adult ECMO at St. Francis before now? So essentially in 1975, they did 20 adult ECMO cases, and they were all done for respiratory failure, and those patients had really good outcomes. And based on that initial 20 patients, they did clinical research for 9 sites, like 9 different hospitals. And so they did a conglomeration of clinical research for adult ECMO from like 75 to 80-ish. And what they found in that 9-center study was that patients didn't survive, and the overall statistics were poor. And so they kind of wrote off ECMO for adults because in that particular study, they didn't see efficacy. So they kind of laid it to the side and spent a huge focus on neonatal and pediatric research. And that's why neonatal and pediatric ECMO has grown so much. But retrospectively, looking back at that time, now they feel like maybe that wasn't a well-designed clinical trial. But for whatever reason, it was set aside. We didn't see it much until about 2000. You had 30 to 40 adult cases a year, and this is in ELSO data. And then by 2009, you had H1N1, and so people were looking for like extreme measures to save lives, so you had a little bit more uptake in adult ECMO. And then by 2010 to 2020, there was a huge increase in biomedical engineering that developed ECMO motors, ECMO pumps, ECMO oxygenators with just better precision, better mechanics, and so there was some improved workflow with the overall design of the ECMO therapy. And then by 2020, we had COVID. And so when we had COVID, again, medical science is looking to the extreme measures because so many adults were dying. And so there was a huge uptake in adult ECMO during COVID. So now, actually, in 2023, There's over 113,000 adult ECMO cases in the ELSO registry, and you would be really surprised to know that adult ECMO today has more cases than neonatal or pediatric combined. So that's kind of the trajectory of where ECMO is going today with medical science. And I want to point out, specifically in regard to cardiac, there's about 1,100% increase in the use of ECMO for cardiac patients, cardiac adult patients. So it's a huge growing field, and so this is really timely that we're putting this program together. So just a little bit about the pump itself. This particular pump is Centramag. It's what we use here at St. Francis. It's the only pump that we have currently. And so it is a free-floating, magnetically levitated rotor. And what that means is it has less hemolysis, less damage to the red cells. It has a better design to propel the blood forward without causing trauma to the blood itself. So it's a very well-designed pump and really is considered to be the Cadillac of ECMO pumps. It is measured in revolutions per minute, and the liter flow for the actual patient flow is in liters per minute. We calculate it based on the patient's body surface area and the cardiac index that we're wanting to achieve. And we always have one backup motor console, with every case. Here's a little bit more of the pictures. You can see over here on the left the design of how that magnet kind of pulls up and spins and propels the blood forward. So here's several pictures, and this right here is the heart. So when we're on VV, it doesn't provide cardiac circulatory support, but on VA, it does provide cardiac circulatory support. So this right here is the heart, and it's about retail at $12,600 a piece. So it's a very expensive heart for the patient. Now, this particular pump is very preload dependent, meaning when we start up the pump and we have this target goal flow that we're trying to achieve, you can ask the physician, like, do we feel like we have, good placement? Could we be up against a vessel wall? Do we have any other factors that I'll talk about in a minute? But volume, volume, volume. So for all the reasons that we like to diurese the patient, especially for lungs, because we don't want all the fluid to sit and collect in the lungs with ARDS, this particular pump has to have enough intravascular volume to have something to pull from to give back to. So intravascular volume is very important with this pump. It is completely dependent on the intravascular volume in order to achieve your target flow. It is also afterload sensitive, meaning that if there's any pushback from the blood coming in, like with hypertension or other factors, then it feels that resistance and doesn't get to flow a steady state flow in. So idealistically, when we were talking about blood pressures earlier, our team does like to have a mean of 65 or greater, but idealistically you don't want your mean like 90 or greater. So you kind of want a mean arterial pressure of 65 to 90, because if it's greater than 90, you're going to have too much hypertension, and that's going to push back against your flow into the pump. You always want to have complete visibility of the circuit and of your cannula sites, and ensure that that pump remains uncovered. Here's a picture kind of just putting it all together, like this is what it looks like at the bedside. So you have a computer screen with 2 consoles and some type of heater. This is our oxygenator, and so what ECMO also provides is oxygenation and ventilation. So for the patient whose lungs are not providing good gas exchange at the alveoli level, then that's what ECMO is helping to resolve. So ECMO is doing this at the kind of blood tissue level. So when we put the pump together, we have a blender, air oxygen blender, and so that air oxygen blender is giving a gas flow of oxygen and pulling out CO2 to add oxygen and provide CO2 removal for the patient. And we can dial up the sweep, dial down the sweep. So really, the ECMO specialist is in complete control of the oxygenation and ventilation of the patient. Now, that being said, they can still be on a ventilator, still be intubated or trached on ventilatory support, but their primary source of ventilation oxygenation should be the ECMO circuit. So when you raise the dial for sweep, so you increase your sweep, then you're going to sweep out CO2 and remove CO2. If you lessen your sweep or decrease the dial, then you're going to let more CO2 come in. This is how the blood flows into the oxygenator. So it comes in at the pre-oxygenator. It fills all the way to the top and has these special filling veins to help promote it all the way to the top before it comes all the way across. And so that gas exchange is happening by diffusion. And here's a picture of the inside. This particular oxygenator that we are using right now, the Nautilus Smart Oxygenator, it is round in design, and they have done that because they have already had the benefit of seeing other companies and other designs and knowing that sometimes when you have corners, like if it looks like a diamond, then you may have some stagnant flow in those far corner areas. So they designed it in a circle so that you have good blood flow throughout the circle through and through with better diffusion and better outcome. The gas is through diffusion in these tiny little hollow fibers, and there's also a water bath that connects to the oxygenator to warm the blood while it's in the oxygenator, but there's not contact at all between the blood and the heater. And our particular oxygenator is computerized so that we can see our pre-oxygenator, post-oxygenator pressures without having to have a transducer. And it also gives us the temperature of the blood circuit as well as the SVO2 and the SaO2 for inlet and outlet measurements. This is just another picture just to show you that the blood essentially leaves the body from the vein, goes through the blood pump, and then the blender is attached to the oxygenator to provide gas flow and oxygen to diffuse, add oxygen, and CO2 removal. The ECMO specialist is the one who's really managing the room, so we need to look to them to be our guide for all the things that we do for the care of the patient, moving them, turning them, chest x-rays, going to cath lab, all those things. Like, they really need to be in control of watching those cannulas and managing the patient. The patient is systemically anticoagulated, so we want to be really careful with any kind of sectioning on them, and not deep sectioning down the ET tube where we might hit the carina, not deep nasal sectioning. But we do use like soft tip catheters for oral, good oral care. Like I said, they're anticoagulated. We could use heparin or bivalirudin, and we have done both. So kind of depends on the patient condition and what their target goals are for the patient. But with heparin, we're going to follow anti-10A values, and with bival, we'll follow PTT. And so now we're going to talk about the different types. So this that we'll talk about first is veno-venous, or VV. So blood is leaving the vein and going back to the vein. Some reasons why you might have VV ECMO is ARDS, really significant ARDS, any kind of pneumonia, whether it be fungal, viral, bacterial pneumonia, any kind of food or chemical aspiration. They might be an overwhelming septic shock. A septic shock patient may be VV, may be VA, probably more commonly VV in our world. They may have severe asthma. They may have some type of vaping or inhalation injury. They could even have smoke inhalation injury from a fire. So we have a patient right now that we're suspecting may have an inhalation injury from drug ingestion. So he may have inhaled his drugs, and sometimes with that, it doesn't just include the drugs themselves, but they're like dirty drugs. So if it has any kind of oil in it whatsoever, then that can really be destructive to the lung tissue. If they have COVID-19 or long COVID, we also have a patient with long COVID right now, so they might also need VV ECMO. Here's kind of the clinical indications of what the physicians are looking for. They're looking to see if the patient has low PO2 despite all of their maximum efforts. So with these patients, when they begin to have a low PO2, typically less than 100, they may add like prone positioning or Flolan, trying to, maximize their efforts. They may do different kinds of mechanical ventilation strategies to recruit more lung. And so they might do neuromuscular blockade to lower their oxygen consumption. So really within about 6 to 12 hours, and this is like idealistically, they want you to assess the patient and see that they're unresponsive to maximum, respiratory or medical therapies given these specific guidelines, and then try to make a decision. So it's they're going to have a better outcome if you have early recognition, early intervention. So our goal is to provide support. So idealistically, once you're on full supportive ECMO, then you want to come down on your mechanical ventilation to rest settings. You want to try to wean off of your Flolan or nitric, and you want to you may still keep a fairly high PEEP of 10, but if you were on 12, you probably are going to come down. A PEEP of 10 is kind of the maximum that they recommend as your rest settings if you're really trying to stent the alveoli and keep them open. So it's not absolute, but again, the whole purpose of this is to rest and recover the lungs. So idealistically, you don't want to stay on high ventilation with high volumes, high PEEPs, high FiO2. You don't need it. So ECMO can be the high FiO2 of 100%, and it's not going to cause lung toxicity. If it's refractory, like we have a patient right now, then after you have proven that ECMO is not enough, then you may add Flolan or nitric or, other higher interventions. Here's the type of cannula for VV. So they have a single cannula that is a dual lumen, and so one lumen withdraws the blood, one lumen returns the blood. And the thing about this particular cannula is it provides the most stability. It's kind of the cleanest, safest access because it's just one cannula, one site with 2 lumens. The only thing about this is it is a very, very position dependent. So the trajectory of flow has to be going into the right atrium and toward the tricuspid valve. And so it could be in the right depth of placement, but then not the right positioning of trajectory of flow. And so then you don't have good flow on ECMO because you might not be able to maximize your flows, or you may cause recirculation. Here's a better picture that kind of shows you that there's holes in the superior vena cava for drainage. There's holes in the inferior vena cava for drainage. But then the target are these 2 dots. I'm going to show you some x-rays, but you're looking for these 2 dots right here with the trajectory into the tricuspid valve. And so that would be like perfect placement for this type of catheter. Now, here's 2 different x-rays. On the one on your left, the farthest one over here, I want you to see that, like right here, there are some dots. And there are some dots as you go down. And the dots are generally about on the correct side, on the patient's right side, but this cannula is too high. So this isn't working, but way up at the top, you have 2 dots on the left, and that's a drainage port. It's too high. So this placement, even though the positioning of direction is correct, the overall catheter is too high. On this chest x-ray, you can see the little dots with the arrows. The dots are on the wrong side. So the dots are on the right, and they should be on the left. So this one is placed probably appropriately in depth, but it's not placed appropriately with direction. So the direction of flow right here is going to be going backwards toward the vessel wall, and you're going to get recirculation because you're not going into the heart. And here's another chest x-ray. And I want to say at St. Francis, when they do their little portable chest x-ray, they take the x-ray and then they have a little button that they push that says processing for lines. And so you want to ask them to take their picture and then hit that little button that says processing for lines, because then you're going to get a clearer picture. So you'll get 2 images. You'll get the real image that radiology is going to read, and then you'll get this one with a crisper, cleaner picture. And then that way you can look at these little holes. And so the dots on the left, you can see that the top 2 dots are right in the superior vena cava. You've got like 2 dots and one on the right. That's just perfect to go into the tricuspid valve. And then the 2 dots at the bottom, and those are the drainage holes too. So this would be a good placement. So again, just more pictures. I'm a real visual person, so I like to have a lot of pictures for you to like put it in your mind and really like comprehend how everything looks on the inside. So we could have, if they didn't want to have a single cannula and they wanted to have, like 2 different sites, they could do a single vessel with 2 different sites. And so that's the one farthest over here on the left. So they have a cannula that's going into the right groin, and that's draining venous flow out, with a cannula going into the right IJ. And so they have 2 cannula sites, but that's VV. If they do that, then your 2 cannula positions, depending on whether they're both up from the groin or whether they're from top and bottom, they need to be about 15 centimeters apart. And then here on the right is another cannula that is a Protect Duo. They only have it in 29 French and 31 French, so they don't have it for those smaller patients. But the thing that's wonderful about this is if you can float a swan, you can float a Protect Duo. And it doesn't have to have that very specific positioning of trajectory, because the flow can just, as long as you're in the PA, then you have good flow. Again, I want to say that this is so very dependent. So what I would say to you as specialists is, like, when you come on shift every day, that needs to be part of your morning assessment, is to check your x-ray. And if you have any changes throughout the day that you feel like you need another chest x-ray, then that might be warranted. But it's something that should be part of your daily routine, to check your chest x-ray to see where the cannula position is, because it's so dependent on having good placement so that you don't have recirculation and so that you can have optimal flow. And here's one chest x-ray where you have like a femoral cannula that's draining, and then a return cannula in the IJ, and those tips need to be about 15 centimeters apart. So the closer they are together, the more recirculation that you're going to have. And we kind of talked about this. This is a good option, and I think that we will see this more and more on a variety of patients. So this can support patients that have right heart failure as well as respiratory failure. So it drains from the right heart and returns to the PA. Drains from the right atrium, returns to the PA. Okay, now we're going to talk about VA, and I'm going to spend a little bit more time on this. This is really kind of why we're here today, is trying to talk about the VA kind of patients. I want to point out that you could have a peripheral cannulation for VA, meaning that you have like fem, like a femoral cannulation that goes into a vein, a femoral cannulation that goes into an artery. So those are considered peripheral cannulation for VA. Or you could have central cannulation, where the cannulas are actually in the heart itself. That's usually going to be after a sternotomy, after open heart surgery and bypass. The cannulas are already in place, and so they may use those cannulas for an open chest cannulation. They may also put an LA vent or an LV vent or even an RV vent in the patient, in the heart, that connects back to the ECMO circuit. We did just do an open heart a few weeks ago, and she had an RV vent and was centrally cannulated. So reasons why we might use a VA ECMO would be pulmonary embolism. And that can be a little bit debated. There might be a physician or a situation that would prefer VV instead of VA, but just typically overall pulmonary embolism, they would do VA support. And what they would do is they would go on ECMO to support the patient clinically, and then they would go to the cath lab for the thrombectomy. So they might do that all in one setting, go to the cath lab, initiate ECMO, and then do the thrombectomy back to back. But pulmonary embolism, I look for that to be kind of a growing trend with our care. They could have any kind of myocarditis or cardiomyopathy. They could have post-cardiotomy cardiac stun, and or they could have difficulty weaning off of bypass. So in our most recent patient, she was on bypass for kind of an extended time. She was a redo heart, so it took a lot of time to get down to the actual site for intervention. And so she had a long bypass time, and they tried again, trying to get her off bypass. And so the physician opted to do a bridge to where we went from bypass to ECMO. They could have severe myocardial depression, and that could be for a variety of reasons. It could be because the patient has overwhelming septic shock. It could be because they've taken some kind of cardiac medication that they've ingested or overdosed on, like to where it is at a toxicity level. Or they could have refractory arrhythmias. And our patient the other day did have some refractory arrhythmias as well. They could be for an acute MI. We haven't really done that yet, but I think that's what we're moving towards, having a heart failure clinic and having heart failure physicians that can manage that long term. And so we may add VA for an MI, or if they had a direct cardiac trauma, like in a motor vehicle accident, or a cardiac arrest for eCPR. So this coincides with your hemodynamic lecture. Like when we're talking about cardiogenic shock and why we're going to go on ECMO, then they have a systolic blood pressure less than 90 or 30 points drop from what their baseline is for their baseline. Their urine output of less than 30 mils an hour. If they have a lactate greater than 2, then they're in shock, or an SVO2 less than 60. They could have evidence of end organ damage, or they could have a decreased level of consciousness. And their decreased level of consciousness is directly related to their shock state of having poor end organ perfusion. So the goal with VA, is to provide mechanical circulatory support to the heart and the cardiac output, as well as help the lungs for gas exchange and oxygenation. So that's our goal. When we put the patient on, the heart will still continue to function. The RV will be the place where the blood drains from, so you kind of reduce the filling volume of the right side of the heart, and you provide good oxygenated systemic circulation to the body, and good gas exchange, and good end organ perfusion when they're in overwhelming shock and have compromise to those end organs. So, again, we talked about a systolic blood pressure less than 90 or a mean 30 points less than their baseline. A cardiac index of less than 1.8 without support, or a cardiac index of less than 2.2 with support. So again, you're trying to have a cardiac index of 2.2 or higher with your circulatory support. And these are all in the context of having adequate filling volumes and fluids intravascularly. So when you are treating your oxygen delivery, it is dependent on the patient's cardiac output or the circulatory support that you're providing, the hemoglobin concentration, the hemoglobin saturation, and the dissolved oxygen. And I was just talking to some doctors yesterday, and so, it's a practice of medicine, and there are thoughts and publications, I guess, on both sides of the line, but the father of ECMO is Dr. Robert Bartlett, and he feels really strongly in these 4 components of maximizing your oxygen delivery. So the whole reason that we are on ECMO is to increase your circulatory support of blood and oxygen to all the end organ tissues. And so one way to do that, he feels strongly about, is to raise your hemoglobin. And so sometimes even pushing the hemoglobin up as high as 14 or 15. And so I know there's publications kind of on both sides of the aisle with that, but the father of ECMO would say push your hemoglobin up higher if you're wanting to get greater oxygen delivery. So, you know, your oxygen consumption is dependent on your tissue metabolism. And so if you have inadequate oxygen to meet tissue demands, then you're in overwhelming shock. And there's 4 different types of shock, but, you know, the goal is, you know, to improve that. And so without that, you'll be in lactic acidosis. Here are the kind of calculations, if you will. She kind of went over this a little bit this morning. But when we are calculating ECMO and trying to decide how much volume of support to be on, then we're taking the patient's body surface area and multiplying it by 2 or 2.2. So I know in our ECMO class here locally, they talked about just taking the body surface area and multiplying it times 2. And they did that because that is a quick and easy mathematic calculation. But as we get more and more involved in these VA cardiac failure cases, then we might tweak that just a bit to 2.2 or 2.4 or even higher, trying to meet the demands of the patient needs clinically. So don't think that just multiplying times 2 the body surface area is enough, because it depends on the overall, you know, condition of the patient's heart and what they need for optimal support. So the goal is to keep their delivery of oxygen greater than their consumption of oxygen. That ratio normally is 5 to 1. For a normal patient, a normal healthy patient that goes and runs track, 5.1, 5 to 1. But for a patient who's in overwhelming shock, and particularly cardiogenic shock, that ratio of oxygen delivery to tissue consumption is less than 2. So ideally, we want it to be 3 or greater in our delivery of oxygen to the patient. And if we're not meeting that, then we may not be meeting their needs. They may continue in lactic acidosis. So as we move forward with this program, there's going to be a whole strategy of, you know, how to manage these patients. And she talked about SVO2, but so you want the SVO2 typically to be 66 or higher in order to assure that you have a, you know, higher ratio of oxygen delivery to oxygen consumption. Your SVO2 needs to be 66 or higher. Now, how does VA ECMO impact the heart? And so she kind of talked about in her earlier talk about the hemodynamics of inotropes and vasoactive meds, but how does the flow itself of ECMO impact the heart? So whether the patient is centrally cannulated or peripherally cannulated, we're going to be draining fluid from the right heart. So from that standpoint, our right filling volume and our right ventricular end diastolic pressure is going to be lower because we're draining. And when we get to the left ventricle preload, we're also still a little bit influencing that to where that could also potentially be decreased. But if we have a peripheral cannulation, and I'm going to show you pictures again here in a minute, and we have a peripheral cannula venous and a peripheral cannula arterial, then we are essentially offering retrograde flow, and so we will essentially distend that left ventricle and potentially cause an increase in the left ventricle in diastolic pressure. So your mean arterial pressure should overall be increased, but your pulsatility in your pulse pressure might also be decreased. And we've seen that in some of our VA cases too. So I've kind of talked about this. Our whole goal of support is to allow the heart and or lungs to rest. And so that's a whole strategy, because like she talked about with adding the inotropic and vasoactive meds, that kind of revs up the heart a little bit. And so it's not necessarily allowing the heart to rest. So we want to strategize to where we are doing the support on ECMO, that our circulatory support is enough for cardiac output and optimal cardiac index without using a lot of inotrope support. Because if we use a lot of inotrope support, then we're not allowing that heart to rest and recover. And the other reason is because if you just throw, like I know we really like norepi and we use a lot of it in adult patients, but you just throw a lot of norepi at the heart consistently, then when you come off ECMO, and now they don't have that circulatory support and it's all them, and they've been used to already seeing the norepi, then they're not going to, or any other vasoactive inotropic drug, they're not going to be as sensitive to it because their body's already seen it. So you want to reserve those therapies for if you need it coming off ECMO. Idealistically, you want to pick that sweet spot to where they don't need much of it. But if you need it, you want them to be sensitive to those inotropic and vasoactive drugs when you come off. So again, here are some more pictures so you can kind of put it in your mind that you could have a femoral catheter that goes up to a vein, to the IVC to drain the blood, and then the femoral catheter that's going back retrograde to the abdominal aorta and pushing the blood flow backwards into the aorta. You could have a central cannulation where you have a direct cannula in the RA draining venous blood, and then you're returning directly to the ascending aorta. And in children, they actually put the aortic cannula in the carotid artery. And the reason that we don't do that with adults is because the potential for plaque, we don't know which patient has plaque, which patient doesn't. And if any of that, having a high flow pressure in the carotid artery could take some of that plaque and just throw it out to the rest of the body. So they tend to be super conservative and not do that approach. So, and this is just to show you yet another, it's not as common, but you could drain from like the right IJ and then go back to the left femoral artery. That could be another strategy. So there's a lot of configurations that they could do. I want to talk about reperfusion cannulas, and we know that this is something that we absolutely have to have. And so fortunately for us, Dr. Weber is a vascular surgeon. He is very knowledgeable and comes to us with a lot of experience with ECMO. And so he has taught all of his team that we will always do reperfusion catheters. So what that is you have idealistically, you have a femoral cannula in one side, a femoral cannula in the other. So I just want to point out that this picture that's on your left, idealistically, you don't try to put two cannulas in the same groin for veno and arterial. You can, but it's just not ideal. Because it's going to compromise the flow a little bit to that leg. But if you do, then you still have to have the reperfusion catheter. And that, I have another picture to show you, is going retrograde down that superficial femoral artery to provide flow to avoid ischemia. So this is kind of typically the center, more of what it would look like with that reperfusion catheter. We use a wire-coiled catheter that actually comes from the cath lab. That's a 6 French 24-centimeter catheter is what we use. It's a Cook catheter that we use for our reperfusion cannula. They put it in at the same time of cannulation, and it actually connects to the ECMO circuit so that it is like sending flow back down the leg. And here's the picture just so you can see like physiologically that they're cannulating their catheter in the common femoral artery up above is where they're cannulating, but then they're putting this a reperfusion catheter in the superficial femoral artery. That's where that's going. And here's a better picture of it so that you can kind of see how the arterial cannula is placed and the superficial femoral artery for the reperfusion cannula. And it's connected back to your circuit. We had discussion on this, I'll just say, about whether or not nursing should be aspirating and flushing this catheter, and the answer is no. So physicians, the physician who's credentialed to place it may come and want to assess it, and we can help them facilitate with whatever supplies they need, but it's not something that you typically do routinely and not something that we should be doing as nurses. So, what are our risks with like peripheral VA? And I've kind of talked about it, that because the flow is coming like this up through the abdominal aorta and kind of backwards, then you can see that you are going to put pressure on that left heart. And that's another reason why we're all here today with Impella, because we want to strategize when is the best opportunity to use vasoactive and inotropic meds to push the flow forward, and when do we need to use Impella to offload the left side of the heart. So it's a strategy, it's kind of a fine line, it's patient dependent, and it really depends on how sick their heart is. But you can see that potentially the more pressure and flow that's generated to that left side of the heart, then potentially you're increasing left ventricular end diastolic pressure, you're increasing afterload of the left ventricle, you may cause pulmonary edema, and so. If you have an arterial pulse pressure that's less than 10, then that is kind of considered stagnant blood flow. So a thrombus might develop in children when they lose their pulse pressure. We're not really too worried about it because they have forward flow with how they're cannulated. And if we were centrally cannulated, like they are, to where, you've got a cannula going into the ascending aorta, then you don't have to worry about your pulse pressure as much, because the work of ECMO is your cardiac output and providing your cardiac index. But when you're going backwards and you don't have pulse pressure, then potentially you're going to have stagnant flow in that left heart and create a thrombus. So if you have central cannulation, then these could potentially dislodge, or you could have an infection risk because the chest is open, or you could even have vessel perforation if you're real aggressive with the movement and turning of the patient. So again, I would say, the the specialist at the bedside is the one who should kind of lead the way in all of the care of the patient. So we just have to the physicians are going to strategize on their approach, what, type of vasoactive and inotropic drugs that they will use, and in what dosing and cocktail, conglomeration. Also, will we need to use an Impella or an inner aorta balloon pump? And if we were going to do a mechanical decompression of the LV, then we could do an atrial septostomy, or we could do an Impella or a true LV vent if they were already open chest. We obviously want to have good intravascular volume, but we may put them on CRT to optimize their overall fluid balance. So, and if our flow was impeding circulation to where their heart is competing, we might turn down our ECMO flow in order to get better output from the heart. And that's kind of counterintuitive, but that might be a strategy that we do. I just kind of gave you this as a reference and a resource for all your different vasoactive inotropic drips. Kind of how do they fall into the strategy of micromanaging these heart failure patients. So, we've kind of talked about this. One thing I want to say on preload dependent, we're going to look for, is the cannula in good placement? Is there any kinks or obstruction in any way? And could it be up against a vessel wall? If not, if we rule that out, then volume. And if volume fixes the problem, then volume is the problem. So let's say that you have 3,200 RPMs on the pump and you're flowing at 3.8. And then you give 500 mils of albumin, or you give a unit of packed red blood cells, and you don't touch the pump, you're still at the same RPMs, and now your flow goes up to 4. Well, then you needed volume to increase your flow. So we talk a lot about what the RPMs are. Really, it doesn't matter to the physician what our RPMs are, it matters what our flow is. But in talking to the physician about volume, then that's where the RPMs come into account, is like how much volume it's taking to get the flow that's desired, based on the same revolutions per minute that were unchanged. And you'll see it on your flow. Like to have steady state flow, not only will you see the chugging, but you'll see it on your monitor screen, it bouncing back and forth. So the other thing that we have to keep in mind is the catheter itself, and later today we'll have breakout stations, but we can't exceed the volume of flow of the cannula itself. So each cannula is rated for a certain flow amount, has kind of an optimal and a maximum, and so we don't want to go beyond the maximum, because then that will cause hemolysis, and it will also potentially cut out to where you don't have steady state flow. So the other thing to keep in mind is when you're troubleshooting, like, do you have any kind of interthoracic pressure? Interthoracic pressure that could be like a pneumothorax or a mediastinal, pneumomediastinum, cardiac tamponade. Do you have intra-abdominal pressure, like from ascites or abdominal compartment syndrome? So here is our native circulation of the patient, and here is this backward flow. And I'm going to kind of end on talking about this, because this is a big part of our strategy in considering the Impella device as an adjunctive therapy with ECMO. So they call that ECPella. like part ECMO, part Impella. Okay, so again, it makes a difference about this flow going backwards. If you have a central cannula, then the central cannula is positioned in the ascending aorta, so now you have forward flow. But here, if you have a femoral cannula, you have backward flow. So, depending on the heart itself and its ability, its own native contractility, that's what drives the, forward flow or not. And so your mixing cloud may be one place today and a different place tomorrow. Like it's something that you constantly have to be reassessing. Where is my mixing cloud in the patient? So adult ECMO is a little more difficult than the children's because you're having to assess for this mixing cloud. So here's a really good picture for me to kind of point out the obvious. But if you have good flow from the patient, good flow from the femoral ECMO cannula, and it's going all the way back here, then you are going to get great oxygenated blood flow to the head and neck and vessels. And you'll get some good mixing to come off to perfuse your coronaries with oxygenated blood flow. But if your heart is working like really hard, and that might be because of inotropes or vasoactive meds, and your heart is really working hard, then your cloud is way back here. Now you have unoxygenated blood that is perfusing the coronaries and perfusing the head and neck vessels, and you only have good oxygenated blood flow going to the bottom of the patient. And here, it could be kind of a mixture of the two. It's partially working, it's partially coming up, so you might have mixing of oxygenated and deoxygenated blood going to the head and neck. You still have poor deoxygenated blood that's going to your coronaries. Like this slide, this concept is really, really important as we move forward with VA ECMO. That's why the doctors will be managing their flow. And here's just another picture of, when it comes off to the coronary arteries, how it breaks off their flow to them. So here's just a picture so that you can kind of see no cardiac function, then you have good flow to the coronary arteries, good flow to the brain, the head and neck. As that heart begins to recover, you may have good flow to the head and neck, but poor deoxygenated flow to the coronary arteries. As they progress and in their recovery and their native heart competes against the ECMO flow, then you're going to have poor deoxygenated blood to the coronary arteries, and you might have some mixed or different oxygenated or deoxygenated blood to the brain. So this, I'll show you a picture of in a minute. You might have to add a third cannula to continue the femoral artery and vein support, but add a third vessel to the right IJ, so you're giving oxygenated blood flow into the right side of the heart. And so we talk about analyzing these patients. This is why having the art line in that right radial is so important. So back to our adult patient that we had recently, she had central cannulations with a left radial arterial line. In that scenario, she really didn't need a right radial art line because she had central cannulation. But But had she had femoral cannulation, or we had changed to femoral cannulation, then that's why you need the right radial art line, and that's where you need to put your pulse oximeter on the right ear and the right hand and right radial art line to assess to see, is there a difference in your PO2 on the right side compared to the rest of the body. And here's just another picture. So what happens in this north-south syndrome is you get a portion or all of the head and neck, right arm, and also maybe left upper arm to be blue, and the lower extremities will be red and pink. Then you know that you are not optimizing the flow. So this is the picture of adding that third cannula back to the right side of the heart. It's not going into an artery, it's going into a vein, but it's taking arterial oxygenated blood from the ECMO circuit, post-oxygenator, back to the right side of the heart in the right IJ, and putting oxygenated blood forward into the heart. Then you're going to have better oxygenation for your coronaries and your head and neck. So our goal is just to optimize perfusion to all the end organs, including the coronary arteries, the head and neck, and provide the cardiac output and support that they need, and that they have forward flow through the heart, and that we're not causing any compromise, that we have good systemic perfusion. So one last thing on our days, there's no absolute number of days. So VV could be about 2 to 3 weeks, or up to as long as 3 months. VA is typically a week, could be as long as 3 weeks. If it was longer, it would typically be a bridge to transplant. But internationally, 75% of all cardiac cases are off pump within a week. So that patient's going to have the better outcome. And there's normally a sweet spot of when to get these patients off ECMO. So you're kind of looking for that sweet spot to find when you've done all of the optimization of care that you can offer, and you don't want to wait too long and get too I don't know what to say, selfish, because then they might have develop multi-organ system failure or sepsis or something like that. And if these patients code, if they're on VV ECMO, then they still need chest compressions, and they don't have to have bag mask ventilation because they're already intubated typically. But if they're on the vent, we want to go to emergency vent settings. You can do synchronized cardioversion or defibrillation, but you want to not touch the pump. So if we're on VA, then that is circulatory support. So with that patient, you don't have to do chest compressions. We actually got to watch our patient have asystole while we continued full flow support, and she was neurologically intact in the end because she was well supported by VA. If you're off pump, then if you're off pump because you come off for air or some type of emergency decannulation, then you're going to have to do chest compressions and increase ventilatory support. This, I just wanted to point out, is available for all of you in Epic under Adult ECMO Summary. So you can see, for your shift, when you give shift-to-shift report, or you're wanting to look and see about this patient, it's a place that you can look to see all the information about the patient's vital signs and ECMO support. And then I've just given you a variety of follow-up resources that you can look at if you want more information. And I will say this particular resource, they have an online class on July 7th. I think it only costs about $25 to attend online, so it's a really good option. So All right, thank you.